I'm happy to welcome you to this new wrist seasonal forum. We just conclude a very incredible, as usual, wrist IRCAD-IWC course with experts and participants from for more than 20 different nationalities. The new director of this seasonal wrist forum are Dr. Shiab Taleb from Mulhouse and Lucian from Marcovici from Roma. They have curated a very magnificent program, and I yield now to Shiab Taleb for the program.
So thank you. First of all, I want just to sum up what we should talk about is the scapholunate instability, and the course will be divided into two parts. The first one, we have 3 lectures about this topic, and the second one will be discussion around cases dealing with this. So the first lecturer will be Steve Moran, and we are really glad to welcome him. He's coming directly from Mayo Clinic, and we are really eager to hear what he's supposed to talk about, open surgery, his own experience. Thank you, Steve.
Thank you for having me, and it's quite an honor to be here. This is about open surgery at an arthroscopic course, just to show you all of my complications over the last 20 years. So I'll start with this case. It's a 35-year-old male. You can see that there is diastasis between the scaphoid and the lunate. On the lateral view, we have dorsal tilt and dorsal intercalated segment instability. But there's also ulnar translocation of the lunate. And I think that this becomes an important problem to deal with. We would consider this a Telesnik type 2 instability pattern. And I think it's important to remember that there are 4 major problems to deal with when dealing with scapholunate instability, and they may occur individually or as a group. We have first scaphoid flexion, we have the diastasis, and if the diastasis is significant, that usually indicates a rupture of the short radiolunate ligament. But the other 2 major problems that we see in this patient are the dorsal intercalated segment instability, which I think, for me, the only way to correct that problem is with a bone tunnel through the lunate. That's the only way that I've been found to consistently fix it. But the other problem that causes most of the symptoms, as we know from Steve Lee's paper, is the dorsal subluxation of the scaphoid on the dorsal rim. Now that can be fixed with a variety of different techniques. And I think, as we heard yesterday from Dr. Corella, that recurrent diastasis after your surgery doesn't mean the patient's going to be symptomatic. So if we go all the way back to when I started, 2003, the techniques that we used primarily at that time were open dorsal capsulodesis, and that's, again, just using a portion of the capsule to control the motion of the scaphoid. And the most common one was the one that you see on the far right, and that is the Blatt capsulodesis. And by definition, that's going to limit wrist flexion significantly. This is a hand surgeon that was sent to me. He had a Blatt capsulodesis done 10 years ago, and he presents with persistent wrist pain. You can see that the scaphoid is in extension, quite a bit of extension, but the dorsal capsulodesis doesn't do anything to control the lunate. And when we scope this patient, you can see that the diastasis hasn't been corrected with the capsulodesis, and he has midcarpal instability. So the only option for this patient at this point, if he was going to return to hand surgery, we just did an AIN and a PIN neurectomy. But it just points to the problems with capsulodesis. And we've moved to other techniques since then. Dr. Berger and Toshi Nakamura both spent a great deal of time working on this ligament bone reconstruction, which was very popular, I would say, for about 10 years within the United States. It's a very demanding technique. It can be taken from the retinaculum of the wrist. Peter Weiss has written on that. Or it can be taken from the capitohamate ligament, which is very stout, and then small screws are used to place this into the back of the scapholunate. A very destructive operation and very technically demanding. Moving on from that, we rediscovered a variety of different tenodesis procedures, originally performed by Telesnik and Dobbins and Lynchide, but they rarely wrote about them because there were many problems with avascular necrosis of the carpal bones. but Dr. Bernelli's original capsulodesis procedure, as you can see in 1995, which was then modified by Mark Garcia Elias to the triple tenodesis, which John Stanley and Mark Garcia Elias performed, and which modifications we still do today. The Corella procedure is a arthroscopic modification of this technique. Within the US, we've had several systematic reviews and meta-analyses to show which of these provides the most benefit. In this particular study by Neil Chen out of Harvard, he looked at 255 studies, but only 40 of them qualified with enough follow-up. And in these studies, tenodesis provided better radiographic outcomes. That's something we also found in a comparative study at Mayo Clinic. But there was improvement in all studies in terms of pain, grip strength, and DASH, but you couldn't show a difference between capsulodesis and tenodesis, just radiographically. Additional studies by Illis coming out of Philadelphia, 1,172 patients from 42 studies found in comparing tenodesis, capsulodesis, and bone ligament bone that bone ligament bone had some benefits over capsulodesis and tenodesis, but not substantially significant in terms of overall patient outcome. We've compared all of these different studies at Mayo Clinic, and most recently combining our data from that of Rotterdam and the Netherlands with Dr. Kort, we produced a study looking at midterm outcomes of the three most commonly used techniques. And by and large, we can't show a significant benefit of one over the other, and the results are not that good. About 1/3 of patients get better, 1/3 of patients stay the same, and 1/3 of patients get worse. In an effort to improve on outcomes, you've seen a lot of advancements in terms of the tenodesis getting more and more radical. And I think we have moved, as Michael Sandow has taught us about the ANAFAB technique. He reported a very small series of 10 patients with 2-year follow-up, and he showed that there was a 75% return of range of motion and 75% of the grip strength restored from the contralateral side. And those results are really pretty much equivalent to everything that I've just shown you, but you're taking on a lot of additional risk here. What this does help control, however, is the midcarpal instability. We're really trying with our bone tunnel, we're going to be correcting that position of the lunate. Another thing that we've learned over the past 20 years is that this technique of exposing the carpus, as was taught to us by Dr. Berger, is probably very detrimental in terms of overall carpal stability. We know now that that incision from the DRC into the DIC is not necessary anymore. And instead of making that oblique incision, we now do most of our procedures that we do open through two smaller incisions. This was shown by Dr. Wolf as well as Dr. Ross, is helping to restore or preserve the secondary stabilizers of the carpus. So this in this anatomic specimen where we've saved the DRC and the DIC, we're going to be working through this small window here to expose the lunate and the scaphoid. And here we are doing an ANAFAB, and this is now the small carpal exposure that we use. You can see that we don't really remove the DIC attachment across the waist of the scaphoid. That does two things. It helps to preserve the secondary stabilizers, but it also preserves a majority of the blood supply. So here we are again performing the post-reduction in an ANAFAB procedure. You can see moving from the diastasis seen on the left to the post-reduction film on the right. And here's the Volar approach, again using a small ligament splitting procedure. The ANAFAB, for those of you that aren't familiar with it, is just a harvest of the palmaris, and then drill holes are created, as have been seen in many of the lectures today, through the scaphoid and the capitate. And that drill hole through the lunate is done with no larger than a 2/7 drill. And then using a tendon passer, we can pass a portion of the FCR first from front to back through the scaphoid, and then back through the lunate, and then finally through the volar side, we'll attach that back to the distal radius to reconstruct the radius scaphocapitate ligament. Then these drill holes are stabilized with interference screws, with the last one being added to the distal radius, and this is the restoration of the anatomy following the procedure. So this patient here, you can see the drill holes in the restoration from the diastasis you saw in the first view, and also the correction of the midcarpal instability. Dr. Sandow has recommended the use of suture tape, but we heard yesterday in some of our lectures that this may cause osteolysis and the potential for cutout of the bone tunnels. So here's the patient with 1-year follow-up. Here's another patient, an American football player, a collegiate football player that requires a great deal of force. He bench presses over 300 pounds, and we used the antifab procedure on this patient as well. 28-year-old snowboarder, again, a similar type of reconstruction in relatively good range of motion, but not to the extent that we saw the other day with our arthroscopic repairs. I really think the results that Dr. Corella showed are world-class, and I think that's what we need to be striving for. Problem with this particular operation is that there's a high risk of osteolysis within the bone tunnels. The patient on the far right, as you can see here, was sent to me after this operation. He has Preiser's disease, Kienbach's disease, and there's even some sclerosis in the triquetrum in this particular patient. So bone tunnels can cause a substantial amount of harm if we're not careful. There have been 2 papers that recently have been published about osteolysis around the peak implants and also a cutout from these tendon tunnels, one published by Dr. Shin and the other one coming out of Boston. With the concern for iatrogenic injury in these bones, we sought to find a more minimally invasive way of correcting scaphoid position. I just draw your attention to this particular case that got me thinking. This was a young patient with painful scapholunate instability, and based on the results of this arthroscopic finding, I thought that when I opened the patient dorsally, I would identify a complete dorsal rupture. You can see that we're passing the scope almost completely through the joint there. But when we open this patient, this is through a dorsal approach, you can see that the dorsal component of the scapholunate ligament is entirely intact. So this is a total volar tear that was causing this patient symptoms. And you can see just by pulling the lunate dorsally, I can correct the small step off between the joint there. So this got us thinking 15 years ago about the importance of a isolated volar repair, and that many of the techniques that were described up to that point really left the volar component of the scapholunate ligament out of the reconstructive algorithm. We looked at ways of using a portion of the long radiolunate ligament as a capsular and attaching that, leaving it attached to the lunate and taking it to the mid-waist of the scaphoid. We described this several years ago in the journal Wrist Surgery in 2015. The technique is very simple and can be done through a small incision, and certainly now that you have all shown me how easy it is to fix this arthroscopically, I would certainly recommend that. We did a lot of biomechanical work at that time to identify the fact that the radioscapholunate and the long radiolunate ligament essentially run right over the scapholunate interval volarly. Through a very small incision, you can just split the long radiolunate ligament and then pull this to the mid-waist of the scaphoid, and that does 2 things. It pulls the scaphoid palmarly, which prevents it from dorsally subluxing, which prevents pain, and we thought that at that time it could correct diastasis. So you can see this is done through a very small incision. There's the approach, very similar to the mid-carpal portals that you described earlier today. And then through this approach, we can identify the scapholunate interval and then take a portion of that long radiolunate ligament and anchor it down to the scaphoid. And that's all there is to it. Testing this biomechanically, we found that the pull-out strength of this particular capsulodesis was equivalent to the pull-out strength of the suture, so that essentially was half the pull-out strength of the ligament itself. The average rupture strength for the long radiolunate ligament is equivalent to about 100 newtons. So the larger suture anchor you use, the better your repair will be. So if you use 2 suture anchors, as we saw yesterday, that can be very effective. So this was one of the first cases we used it on, a 56-year-old surgeon. Here's the repair. And at 3 years out, he had returned to sports and had continued to practice surgery. This was a 22-year-old American football lineman, 4 months of wrist pain. On arthroscopy, you can see he's got a fair bit of hemorrhage. He's got a step off there between the scaphoid and the lunate, and a pretty big tear of the volar aspect of his wrist. Here he is almost 4 years later. You can see that he has a correction of his scapholunate diastasis. You can see also we did a TFCC repair at that time with very good preservation of motion. We are going to be presenting our outcomes of this at the American Society for Surgery of the Hand. We have almost 8-year follow-up on 28 patients. The majority of them had grade 3B injuries, but 7 of them had grade 4, so drive-through sign. And you can see again, the range of motion and the strength is just a little bit better than everything we've reported, and is that statistically significant? I think the important thing about this particular study is that we were able to capture DASH and patient-rated wrist exam on all these patients. And for those of you not familiar with the DASH score, basically, once you recover from a closed distal radius fracture, most people have a DASH score of 12, and you can see here the DASH score in these patients is 16. There was a 10% complication rate. One of those was recurrent diastasis, and 2 of them were surgical infections. So I think this technique can be performed much more easily arthroscopically. I think we have the potential to fix many of these injuries with relatively minimally invasive technique. And again, what we're doing is pulling that scaphoid palmarly. And you're going to say, how do you know that? Well, we've spent a lot of time and effort looking at 4D CT scans. And what we do with the 4D CT scan is essentially we're using artificial intelligence to some extent, looking at the space between the 2 bones after we do repair. A lot of this work has been done by Dr. Kokar and his research group. But essentially, what we're seeing is when we look at this particular repair, if you look at the preoperative space between the scaphoid, you can see that yellow and the green, it's riding up on the dorsal aspect of the scaphoid, on the radius, creating pain. And after we do the repair, the scaphoid is pulled more palmar and it approaches more the picture of the distal radius that you see at the top, the hot yellow spots where there's very little distance between the scaphoid and the radius have been corrected. So biomechanically, the volar capsulodesis can really improve the biomechanics of the scaphoid. Again, this last case, again, a volar tear, and at 3 years follow-up, you can see very, very good motion. So in light of time, we'll skip the present arthroscopic repair now, but I've moved to mainly a box-type technique, though I think that Corella technique, after what I heard yesterday, is very attractive and very appealing, and I think that we'll try to start using that. I think the problem for many of us in my 20-year career is that I do tend to change my technique every 2 to 3 years, which makes long-term follow-up on any of these things very difficult. But I think we know now that open approaches have led to less reliable results or equivalent results to what we can do arthroscopically. I think arthroscopic repair is much safer because of preservation of the blood supply. I think volar capsulodesis or volar plication, in addition to dorsal repair, may improve outcomes in conjunction with newer approaches to the carpus, but obviously more clinical data is required. Thank you.
Thank you, Stephen Moran, for your amazing presentation. I want to call Fernando Corella, which we are honored to have with us. He has an amazing experience with arthroscopic scapholunate reconstructions. And I want to remember the chat that you can make questions. There is Alam that controls the chat. And also
yes,
us.
We will answer at the end of the lectures to the question.
Okay, thank you.
Okay, so hello everyone. Thank you very much for the opportunity to be here again in this session. It's a pleasure for me to talk about this fascinating topic that is changing every year. So the lecture of today probably won't be the lecture of next year. So these are my conflicts of interest. Well, as all of us know, scapholunate injury is not like a broken or not broken rope, as other ligament injuries could be, like the LCA of the knee. This is much more complex. This is a spectrum of pathologies known as scapholunate dysfunction. This name is important. This dysfunction can be treated with a myriad of techniques. So in an attempt to organize how to choose between them, my good friend Ricardo Lucchetti and I developed this forearm algorithm treatment that we published in the Facebook of last year. And we did a recommendation on how to choose between 4 different groups of techniques that include techniques for repair, for reinforcement, for reconstruction, and for bone resection. And each group can be done arthroscopically or by open surgery. But to choose between them is essential to exactly define the stage of the dysfunction. And for me, the best way of doing that is with an arthroscopic exploration. So this is the algorithm we have proposed. The first thing to differentiate is an acute or a chronic injury. Most of the time there is no doubt this is acute and this is chronic, but sometimes, especially in case of trauma, we may have doubts. So this is a distal radius fracture. So this is an old injury. There is no blood in the stumps of the ligament. So we should not treat this case. But this is acute. You can see a fresh injury and the fresh stumps of the dorsal portion of the scapholunate. So this is acute. So in an acute trauma, check for blood, check for signs of fresh injuries. So in acute injuries, the technique is the repair. And we can do it arthroscopically, for example, in this perilunate injury, that is the detachment of the dorsal complex of the scapholunate from the scaphoid. So we can put an anchor and make a direct repair of this detachment of the dorsal portion back to the bone. So normally we put an anchor, pass a loop, and reattach this dorsal complex directly to the bone. But as Steve has said, remember that apart from the dorsal portion, dorsal complex, is also important the volar portion and also the volar complex. And most injuries go from the volar side to the dorsal side. That is why it's common to find associated with a dorsal injury, a volar injury of the scapholunate, or even an isolated volar injury. That is why we, following the idea of Paco Piñal, we have just published this. It's available online. It's a way of doing a reattachment of the volar portion of the scapholunate. So we put an anchor, retrieve the threads of the anchor with a knot pusher from the dorsal side, take the anchors to the dorsal side, then pass an avocat loaded with a loop, recover one of the threads to one side, and then we do exactly the same in a more angular position. So this way we have a U suture with the knot in the volar radiocarpal portal, and when we knot, we take back all the ligament and complex back to the bone. So this is an example of an acute injury, distal radius fracture. You see, in fact, it's a small fragment of the bone detached from the lunate. So we perform the volar radial portal, use the detachment of the capsule to put this anchor in the area where the ligament is detached, change the arthroscope to the ulnar side, introduce the knot pusher and recover the two threads towards the dorsal side, and now try to capture from proximal to distal as much tissue as possible to make this reattachment of the volar side of the scapholunate joint. So one thread, the second thread. So you can see the suture, and we knot and left the knot outside of the grease. So for me, techniques for repair really works. More difficult chronic injuries is a great challenge. So the first thing we decide here is if it's a ligament remnant of a knot quality or no. We have published this test called the hook test, trying to see, if the quality of the dorsal complex is okay. So you can see there a really thick dorsal intercarpal ligament in contact with the dorsal dorsal scapholunate ligament, and there is a stump with no remnant, so there is no healing capacity of this small ligament. Again, this grade 3C, but there is continuity in that ligament, so we can do a technique for reinforcement. Obviously, you can do in the dorsal side the technique of Christophe. We do a similar technique. Normally, we put an anchor in the dorsal side and pass a loop the same way. We recover the loop from the radial midcarpal portal and do this suture with the anchor, and when traction is applied, all the complex is corrected to the bone. But again, in the volar side, we can do the same. We can put an anchor. This is a chronic injury, so it's to reinforce the volar scapholunate complex, and we do the same. We do a capsular emta suture close to the scaphoid and then close to the lunate. And you can see how is the aspect after the attach the knot. So you can do that in the volar portion or combine in the dorsal and volar portion. And for me, these techniques also works. So what about if there is no ligament remnant of enough quality? Well, the next thing we check is if it is reducible or not reducible, and we also check that arthroscopically. It's a negative hook test, but with the probe we can put back the scaphoid to its normal position. So this is reducible, and this is not reducible. This is static. So if the injury is reducible, we go to reconstruction. As Steve has explained, there has been capsulodesis and ligamentoplasty through the years, and there is not a clear recommendation between one and another. It's the same now. We have arthroscopic ligamentoplasty, also arthroscopic capsulodesis. I'm going to talk about this technique that we have been doing for the last 12 years. And as every technique, it has its pros, but also its cons. The most important pros is that it's a double reconstruction. So we reconstruct the dorsal side and the volar side, and we use interferential screws, so no KWS are required. Obviously, it's an arthroscopic technique, so less scar tissue, less desvascularization of the bone, and the proprioception is preserved. And it's a studied reconstruction that was demonstrated in this biomechanical paper, and also allowed the patient to move early. So this is a really quick video of the technique. So we make two tunnels, one in the scaphoid and one in the lunate. The graft is a 3 mm hemitendon of the flexor carpi radialis. We pass through the scaphoid bone, and when traction is applied from dorsal, the first screw is introduced from volar. Then we pass the graft inside the lunate, and as we traction from volar, you can see how the instability is reduced and the second screw is introduced. And finally, we attach the graft with this small anchor in the volar side, and we also can make a reinforcement with the tape. So this is the difference between preoperative with instability and the step of disappear. It was a reducible instability, and the most important thing is this dynamic dorsal displacement of the scaphoid that is completely detached. Now all the proximal row move together. So for me, also one important pro is this, is the clinical result of the patient. We can have patients like this with nearly complete range of motion, grip strength, and improvement in pain, grip, and in the DAS score. But unfortunately, this technique also has some drawbacks. The first one, and probably most important, is that technically is very, very difficult. You have to be accurate with the tunnels, work closely with a skilled surgeon who operates on the volar side, manage the tape, the graft, introduce the screw without breaking it or losing it. So there are many steps. The second drawback is what Steve has also said, is the complication of collapsing or necrosis of carpal bones. It's true that we have been doing this technique for several years. There have been many techniques that do tunnels, the tenodesis of Mark, the procedure of Sanjay Kakar, the ANAF procedure, even the PCHO box technique. So I don't think it's really common, but it's really severe. So this worries me a lot, and we have to talk about that. And the third drawback is this: I have shown you 4 excellent clinical results, but the X-ray is not perfect always. It's far from perfect. Many times there is a recurrence of the gap. The two on the top that was clinically really well has this open gap, and you can see that I have X-ray with open and with closed gap. But as I told you, even if it is a recurrence, the clinically they do well. In this paper, you can find the clinical result of 46 patients. So it was an improvement in pain, in grip force, in the DAS score, maintaining more or less the similar range of motion. But why is this? Why, even if it is an open gap? Probably because patient has pain because this dorsal displacement of the scaphoid over the dorsal rim of the radius. And if you make a reconstruction or a technique that avoids this dorsal displacement, patients can improve with the grip strength, and they are doing well. And furthermore, in my experience, the recurrence of the gap is really early, between the first month and the third month, like in this patient. But it doesn't progress. So this is 1 year, this patient, 2 years, 3 years, 4 years, 5 years, 6 years, and there has been no worsening, no slack wrist. This patient is a fireman. You can see after 6 years, he continued doing his work, climbing, and this is the range of motion. You can see there the scars and the grip strength and the improvement in data. Also, this is our longest follow-up. This is the woman we used for the first paper. So this is 12 years of follow-up. You can see the X-ray is quite similar and still with a really good range of motion and improvement. You can see there the scars and improvement in the grip force. So things has been developed, and nowadays, since 12 years ago, many things has changed. The first one is that now is an improvement in knowledge. We know that the FCR is a really important secondary stabilizer, and most important that the extrinsic ligaments are essential for scapholunate injury. That is why capsulodesis has going bigger, and nowadays I think we are moving to trying to capture all this dorsal intercarpal ligament, like the supercapsuloplasty of Mantovani, and that is why in the last 2 years we have tried to add this concept to our technique. So we have made several changes. The first one is now we use a free graft. That's why we can do a pretension, trying to not get loose after the surgery. And we do a biological reconstruction, but also a reinforcement of the extrinsic ligament. So this is called the double circle ligamentoplasty because we have a biological circle that reconstructs the scapholunate, volar, and dorsal, and also a reinforcement of the dorsal extrinsic ligament and volar ones. So technically, really the new steps, we now perform a blinded tunnel, so only one cortical in the scaphoid in the dorsal side and also in the volar side. We use this free graft. So we fix again with one interferential screw, pass the graft again intra-articular, put the screw in the lunate, and then fix with this small new interferential screw from the volar side. And finally, we make a reinforcement of the extrinsic ligament in the volar side, and over the capsule, trying to go radial in the scaphoid to the lunate, the extrinsic ligament. So we push a little bit the technique in more complicated cases like this one. You can see there is no remnant of the ligament, a huge displacement that disappears after the technique, and radiological, you can see that this dorsal displacement also disappears. And this is the same case, 1 year follow-up. Another case, huge step off between the bones after surgery with the X-ray. Another case with a really important grade 5 instability with a recurrence of the gap. And this other one, again, a big step off. And this is the X-ray. But this technique has also drawbacks and is even worse than before because technique is much more difficult. You have to be really accurate. Tunnels are thinner, but you have to be accurate with the tunnels. And also, even in this case, with a double reconstruction, a reinforcement of the extrinsic ligament, we have a recurrence of the gap like in this case, but still with good clinical result, as you can see in this patient. So for me, it's really important also to talk about this, about the difficulty of techniques, because not every technique arthroscopically is the same. We always talk about this kind of mountain with difficulties in different techniques, and we organize several courses. You cannot go for ganglions or fractures to ligamentoplasty. You have to climb in that mountain. So if you want to do safely a ligamentoplasty arthroscopic, you have to be able to do volar and dorsal capsulodesis, do perilunate injuries, do scaphoid non-unions comfortable before doing ligamentoplasty. It's not like a LCA of the knee. So after everything is changing. So for me, this reconstruction, we still don't have the solution. And what about this if it is not reducible, and that happens if the gap is quite open or you have degenerative lesion? Well, here we don't do anything. As in this case, this was not reducible. Look at this dorsal displacement. Before doing a four-corner fusion, we just make a resection of the dorsal side and wait until the patient wants this. That is a four-corner fusion. And also you can do this four-corner fusion arthroscopically. As I showed this morning, you can work from the volar side. You empty the inner portion of the bone, resect the peripheral portion with this pituitary rongeur. And for me, it's useful to work also in the volar side because you can reset only the cartilage looking from dorsal and also looking from volar that to resect the dorsal horn of the lunate until you make the exposure of the bone, and then just 2 screws, 1 capitolunate and then 1 trichetohamate, and this is all. And for me also, palliative salvage procedure works. So the take-home message of this lecture is that scapholunate ligament is really complex, it's a dysfunction. There are different treatment. Arthroscopically is the best way of staging the instability, but nowadays all the techniques, repair, reinforcement, reconstruction, or even resection, can be done arthroscopically, and for me this is quite an advance. And remember this, not every technique is the same. You have to be careful in growing, in doing more and more complicated techniques. If you want to do ligamentoplasty, be sure you are able to do this other technique, and that is why we are here. And thank you, Christoph, for your work teaching, because you need to work in cadavers before working in patient. Thank you.
Thank you, Dr. Corella, for this really outstanding lecture. Now we welcome Dr. Kakar. He will try to explain us what about the volar aspect of the scapholunate complex in scapholunate instability. He's coming as Professor Moran from Mayo Clinic. Thank you.
Allez, si, elle a lancé.
Okay, thank you very much. Thank you. It's an honor to be here today and for this wonderful course. And I'd like to actually thank Christophe for the inspiration of with this technique after I saw and learned his dorsal technique. I'd like to all invite you to Maui this May. This is the combined meeting for the American Society for Surgery of the Hand and the Australian Hand Surgery Society. So if you fancy some sun and some fun, please come in May. A lot of the videos and pearls that I'm going to be sharing are on Hand E, so if you have your phone out, this is the QR code, which is the digital platform from the American Society for Surgery of the Hand. You just need a login and a password. It's free to join. So start off with an index case. So this is a patient that came to see me as a manual worker who had fallen and was complaining of anatomical snuff box pain. And if you look carefully, you can see this totally non-displaced scaphoid fracture. And I would argue if that was your wrist or definitely my wrist, I would pick a cast. And that's what we did. And he came back 3 weeks later and he had been researching and he said, you know, I've heard that these bones don't heal, so I want to get this fixed. So no problem. So that's what we decided to do. So typically, when I fix a scaphoid, I put my K-wires in, and I always check my reduction arthroscopically because sometimes you can be off in rotation. And I think if you look at this, you would probably agree that the reduction looked pretty good. So I thought, okay, this will be a straightforward screw and we're done. When I went to look at the scapholunate, you could see now the instability on the volar side. The dorsal side was completely stable, but volarly was off. And so the question is now, how do I treat this? If I put a screw in, which I did, do I treat this in a cast? Do I put a scaphocapitate pin? What do I do? And so the question is, how does one address this type of injury? As we've heard from Dr. Moran, Dr. Correa, there are numerous factors that one needs to consider for the treatment of scapholunate instability. And this probably was the paper that I read many years ago that sort of opened my eyes to the spectrum of type of injuries that we have. For me, in the operating room, that's kind of a hard thing to use when I'm with a patient. So I use this acronym of SCARE. So I consider the secondary stabilizers or the critical stabilizers. What is the quality of the cartilage like? Is it arthritic or not? The alignment of the carpus, as Dr. Moran showed, is there dorsal scaphoid subluxation? Is there lunate ulnar translocation? Is it reducible or not? Is it a chronic injury or is it an acute? And finally, where is the location of the injury? Is it dorsal? Is it volar? Is it through and through? So for me, arthroscopy plays a very powerful tool to try and answer these questions. Will Geisler came up with this classification many years ago, and I still think many of us use this, but thanks to Dr. Messina's work using this EWAS classification, I think what I liked about this is that it would really tailor where the injury was to direct treatment. So I had the privilege of visiting Christophe many years ago, and we heard about the history of the capsulodices. And it was only until I saw the power of that operation did it really open up my idea of how we can use the capsule on the volar side. So Christophe, thank you. And if you look at his series, and there's many series out there of obviously 57 patients, we've heard how these patients actually do despite getting the gap. And I saw this 98% satisfaction rate. So to me, this was a very powerful study to try and delineate how to treat scapholunate instability arthroscopically. So taking those pearls in mind, how do we do this from the volar side? And so very straightforward. You take an 18-gauge spinal needle, and you load this with a 2.0 non-absorbable suture, and you load it from back to front such that you have the tails coming out of the tip of the needle. Just show you some schematics now, and then we'll show you how to do this technically. So from the volar side is typically a volar radial portal where you take the FCR radially and the median nerve ulnarly. You can't actually see the volar scapholunate ligament from the dorsal side, and essentially what you're doing is you have the camera in the ulnar midcarpal portal, you bring the needle through the radial midcarpal portal, pierce the radius scapha capitae or the capsule adjacent to the scaphoid, pull the needle back, but stay within the radial midcarpal joint so you don't get a soft tissue bridge, and then take a bite of the capsule adjacent to the lunate and tie it on the palmar side. So here, the camera is in the ulnar midcarpal portal. You can see on the far side, the needle is pushed through the capsule, retrieve one limb of the suture, pull the needle back, but stay within the radial midcarpal joint so you don't get the soft tissue bridge, and push it through to the capsule on the lunate side. So we've gone through the radial side, and we're simply pushing it through the ulnar side. You do have to know your anatomy, and so as you can see where that star is, that the median nerve is there, but we're hand surgeons, we're comfortable on the volar side, and you need to retract this out of harm's way. I have to thank Dr. Correa for teaching me about the volar central portal. I would say 8 times out of 10 it's a volar radial side, but sometimes it's on a volar central portal. And you can see here with the power of just one stitch how it's pulling the volar side of the scapholunate joint back into a reduced position. This is a very short cadaveric video showing how to do this. So there you can see the portal. You can see the camera is now in the ulnar midcarpal portal. There's the needle coming in. You pierce this through the radial midcarpal portal. There you can see the step off of the scapholunate region. Obviously, the probe is important to look at the reducibility, as we heard. Where's the location of the injury? And also the quality of the cartilage. And so invariably there's scar tissue, sometimes blocking or reduction. But sometimes you can make an irreducible or reducible step off. So the needle comes in, you take a bite through the capsule adjacent to the scaphoid, simply pull it out volarly, pull the needle back but stay within the joint, and then take a bite of the capsule adjacent to the lunate. It's as straightforward as that. And so now you simply pull the needle back, and you can use that suture to assess your reduction of the scapholunate joint. And so you can see once the needle has been pulled, how just by pulling on the suture, you can reduce the step off. And so many have described this. So this is, as we heard from Dr. Correa, this is Paco del Penal's. It's an outside to inside technique as opposed to an inside to outside. But sometimes the capsule isn't attached to the carpus. And so thanks to Fernando for sharing us this technique of now, even when the capsule is stripped off the carpus, this is a useful adjunct. We heard from Dr. Moran in terms of doing a mini open approach, and it's nice to see the longevity of the results that he had shared with us. So that was one case. So what about this patient? Comes in with a 2-year history of dorsal radial wrist pain, tender over the SL with also pain on wrist extension. And when you look at the MRI, I urge you, when you look at the MRI, don't just look at the coronal, look at the sagittal. You can see you guys dorsal impaction, but also train your eyes to look at the axial view of the MRI. And you can see this is a complete through and through injury. And so here, when I'm scoping this, you can see the cartilage is actually not too bad. There's a big geyser 4 injury. I can drive this both dorsally and volarly through this. And remember that don't just go off the x-rays. And so here the suture has been passed adjacent to the scaphoid. We'll back the needle out and we'll push this adjacent to the capsule by the lunate. And so by pulling on that one stitch, you can see how we've taken something and we've reduced this on the volar side. So there I've let the traction off, I pulled this and I got the reduction. However, it wasn't perfect. This patient also had a dorsal injury at the same time. So taking the principles that we've learned from the dorsal capsulodesis, remember the camera's in the 6R portal, you want to shave away, get rid of all that scar tissue so you can drop your hand and then pass the needles as we've been taught. And now you can see just simply pulling on those dorsal sutures how the blood sort of comes between the bones and we get a nice reduction. Obviously, the beauty of arthroscopy is we can address multiple pathologies. Dr. Moran showed in his patient fixing the SL and the TFCC. This patient had a wrist impaction, and so you can see with arthroscopy we can also address that. So this is a very small early series, just of 6 patients, mean follow-up just under 9 months. What we notice in these patients, it's not just a volar injury, sometimes it's a dorsal injury and you have to assess that and also treat concomitant pathology. In 2 of these patients, the reduction wasn't perfect, and so there's no problems in pinning. We've learned that from Christoph's work, that sometimes pinning does help. And as we had seen earlier, I think having patient-reported outcomes is important. We can report on gaps and angles, but really it's the patient's function that is critical, and these patients did okay. And what was nice to see was a reduction in the scapholunate gap and the radiolunate angle. So in summary, as we've all seen from these 3 talks, really understanding the spectrum of injury I think is critically important, and tailoring your treatment on an algorithm is certainly the way to go. Lastly, I'd like to all invite you to Rochester, Minnesota in June. This is a course by our partners in spasticity, so please feel free to come and join us in June, and thank you very much.
So it was an amazing session, and we fronted the scapholunate all over. Let's start the discussion.
Okay, so it's very interesting because we have several points to discuss, and if you accept, I would like to discuss step by step the different things. We can use, if you want, the 4R proposal by Fernando and Ricardo, because it's interesting, and we start with the acute case, and I think everybody agrees now that the problem of acute case is no longer a problem, because if it is a non-static dynamic case, a simple immobilization, 6 weeks in a normal position, obtain the good result and the good fixation, and if not, you perform arthroscopic suture or what you want, it works. The second R is very interesting because it is a classical technique, and in fact, my first question, because it is really important, we have, in fact, to see and operate the patient at this stage. That is a stage important, and we have to see the patient at this stage. We are lucky in Paris because every medical doctor or sport doctor or kinesiotherapist are completely educated, and we receive the patient at this stage very often. It's very rare to see the patient at a static stage, in fact. We discuss after for these cases. And my first question to the panel is, how do you do the diagnosis of scapholunate instability? Fernando, you want to start? Push on mic.
Yeah, for the diagnosis, clinically, I touch the dorsal portion of the scapholunate, also the volar side of the scapholunate. I do the test of the extension of the fingers. This is a really sensitive test. And then the Watson test, clinically. Also for me it's useful, the flapping test, because you relax all the dynamic stabilizers. So if a patient can do that, it's not probable to have an injury. So that for a clinical point of view. Then fortunately I have an ultrasound in the clinics, so I do ultrasound. I think we have to work in the ultrasound because probably that will change many things in the future, trying to see not only the gap but the dorsal displacement dynamically in the clinic. And then normally I ask for dynamic X-ray, closed fist, ulnar deviation, and now in the hospital we have like a dynamic fluoroscope that they record all the motion, inflection, extension, so also in both hands.
Comparative.
Yes, that's
essential.
Essential, that's essential. And finally, I asked for an MRI. And sometimes in static, also for a CT scan to see the position of the bone. So that is how I
So in summary, clinical interrogation, of course, clinical examination with some tests in order to have your index or thumb is good too, very important. Tim Herbert explained me that the clinical examination for him in chronic pain in wrist chronic pain, is to ask to the patient with a safe index to show where is the pain. If he puts the finger here, it's scapholunate. If it's here, it's a TFCC. It's 95% of cases. A try is true. So it works very well. So the first thing is that, is your thumb. And after that, the X-ray. With dynamic comparative X-ray, you have a majority of information. And of course, MRI could be a solution. Do some of you perform CT scan?
So a couple of things, Christophe. We looked at our outcome on diagnoses of scapholunate, and we found that with normal X-rays, stress views as well, they were in 42% of the time completely normal and had a stage 3 or 4 instability on arthroscopy. So while I think X-rays are useful, I think the clinical exam is key. We have, as Steve showed, 4D CT at Mayo, which is more of a research tool as opposed to a clinical tool, but we're using that to look for instabilities as well.
Okay, so someone want to add something about the problem of diagnosis? So it is really important because you have to educate the person with who you work, because it's important to see the patient at this stage. That is the first point. And if you treat the patient at this stage, you obtain a very, very good result. Now we arrive at a very complicated problem. It is the third R. The third R is the patient, and we can see a lot of patients like that. And for me, I appreciated a lot the different options proposed by many of colleagues, Alam, Gustavo, Fernando, Ismail Boulant, etc., etc. And it is my first question. Do you think that it is necessary to reduce the gap or not?
I think I always try, but as we've discussed, many of the times patients come back and the gap can come back, but their symptoms are much improved. And I think as Fernando and Steve had mentioned, it's the correction of that dorsal translation on the scaphoid facet, which I think is the most important.
Steve?
Yeah, I was just going to say, when I visited John Stanley, he told me never to get an X-ray after you do the Brunelli. He said never. And I think when the patient sees the X-ray,
Good idea.
when they see the X-ray, they're like, you told me you were fixing that gap, and now it's come back and it's mental. I don't know if they're having pain, because there are many patients.
You have to give him the safe wrist X-ray.
Yes, turn around.
Yeah, it's good, very good.
I always get them in a little bit of pronation that makes the gap smaller in the operating room. So I think it's working with the patient also to know that they may still have some pain afterwards with heavy gripping, but if you've closed the gap, I mean, we don't know if any of these operations prevent the onset of arthritis. We know, though, that patients can go back with low DASH scores for at least 10 years with some of these operations, and we prevented them from having significant wrist pain. So I don't think we really know the long-term outcomes yet.
Okay.
Sorry, I have just a short question for the faculty. So how do you follow your patients? If some patients, they come back with an MRI after postoperatively asked by the GP, and of course it's not really useful. Do you ask some CT scan to follow the DST, to follow the patient after the surgery? Fernando, Sanj, Steve?
So for me, the follow-up, I see the patient really few times until the 6 weeks. Then at 3 months, 6 months, 1 year, and every year I try to follow up. It's in the way, the place I work. So 6 years ago is more difficult. I have lost some patients, but I try to see every patient. If something happened, they came. So I think I have most of them more or less controlled. Normally I do only X-rays and clinical exploration, grip force, pain, and range of motion, and the DAS score.
And do you think the X-rays are enough?
If everything is going well, yes, I mean, if something is bad or they fall, I do a CT scan, but normally I don't do the
A
follow-up.
normal CT scan, not an MRI. Yes.
Yeah, I totally agree. X-rays, I don't get CT scan or MRI post-op. The other point that I wanted to mention, especially in the pre-op workup, I look at grip strength. And grip strength is an important marker for me because if a patient has a scapholunate ligament injury, but their grip strength is exactly the same as the other side, I may be a little bit more conservative in doing an operation then.
Do you have some questions from the chat, Adam?
Yes, so we have some question for Melanie Amarasuria, which is connected. I think the first question is for Steve. For the technique you showed, was it isolated palmar ligament reconstruction, or did you combine with a dorsal reconstruction?
Yes, 7 of the patients had a complete injury, so they had a dorsal capsulodesis and a volar capsulodesis.
And for what is your current techniques for dorsal tears? That is literally the question of
my
Melanie.
technique now is all arthroscopic.
Okay.
Yes, and I even think we haven't gotten there yet, but even for, I think arthroscopic approach initially is always best to see how the patient does, understanding if they fail that, they may need a larger reconstruction afterwards.
Okay, so we answered to Melanie, thank you. And I think the second question is from Eleni, and I think the question is for Fernando. What about your results regarding pronosupination in these patients? Or I think also for
No, the pronosupination is good. I don't think that's...
there's no...
It's true that in extension, I explain them to do push-ups, no? Don't try to avoid that because it's the way they get injured, so try to do everything with a closed fist, really strength, and in neutral position. But the pronosupination for me is not a big deal.
Okay.
Yes, I have 2 more questions. I think I have seen in your presentation in a movie that you make the suture in traction. And it is just because you perform a movie, or normally you remove the traction when you do the suture?
Yeah, normally I do all the technique in traction. I mean, the tunnels for me is more comfortable. You don't have to move to enter the X-ray. And when I am touched, I release a little bit the traction and see that you correct that. So no, I don't put the hand back in the table. It's also difficult because, for example, Mireia say that when traction it closes a little, so I'm not sure the best solution.
Maybe you have to try because probably you decrease. I think it's not important to have a gap, but maybe you can decrease the gap.
Regarding the gap, I think all of us would like to have perfect X-rays. I can show only the perfect X-ray, that would be fantastic, but it's not true. So I think gap, obviously, if it is a requirement, something is happening. But the thing is, what is the clinical importance of that?
So it's why, for the 3R, everybody has problem with this section of chronic between large static and large dynamic and static case. And I think the most important is to obtain a combined movement of scapholunate bones, the coupled scapholunate bone. If we obtain that, it's probably better than to have a good reduction of gap with all the problem created, the iatrogenic problem created by the complicated technique. So it's why I suggest you to be quiet, because you see Evan Fernando, who is a very great surgeon with a long standing and follow-up in this procedure, said that I'm not happy. And Steve explained us, I'm not happy too. So it's very complicated. So the aim is to restore something in order to have a combined movement.
Okay. Last question from the chat from Gustavo. And Fernando, you can come to...
Yes. very, very quickly. I think it's for everyone. We partially answered already to this question. Do you give any importance to the time from the injury to the surgery? Do you think it may decrease the healing potential over time? If so, how long after the injury it is safe to do a repair? And how long it is safe to do a reconstruction? I think for Nando, Sanj, Steve, everyone, short.
Yeah, so I don't see the patients early, to be honest. I think we're lucky if we do. So for me, when I see these patients, I say we're going down one of three pathways. We're going to scope you, and if you're arthritic, then we're looking at maybe like a partial denervation. If I can get you reduced with a capsulodesis pinning, we're going to do that. If we need to come back to do a formal reconstruction and I can't get it, like an SL360, then we're coming back another day. And that's sort of the pathway that I go down.
I just say we don't know the natural history. Many of these patients have had partial injuries forever, and then they fall and have a distal radius fracture, and now it's a diastasis. If it's a large DC, I think they need some type of ligament tunnel with a ligament reconstruction. If it's a wide gap with ulnar translation, I think they need a ligament reconstruction. But otherwise, they would get an arthroscopic. It's regardless of the amount of time. It's the examination of the ligament under arthroscopy.
So we are continuing now with the second session with the clinical cases, and we will continue to discuss with the clinical cases all the aspects that we started to discuss earlier. So, Fernando, your first case?
Yeah. So this is a very complex case, not specific scapholunate, but this is a clinical session, and I think we can learn a lot about why arthroscopy can be essential in many different aspects. So this is a 16-year-old woman with hypertension, dyslipidemia, hypothyroidism, and she had a car accident with trauma in the wrist and chest. She was diagnosed of fracture in the sternum without fracture in the rib or pneumothorax. And these are the initial X-rays. This is the X-rays with the cast, so you can see anything. And here again, the X-rays. So, may I ask the attendees? So, with this X-ray,
The panelists?
Yeah, we have five young panelists. They attended the course.
Be careful.
Yeah. So the first one, what do you see in this X-ray, and what would you ask for any other examination, any other thing?
How about you, Anna?
Yes, I would like to have a CT scan a little later, but what I see is the purulent luxation of the corpus and then the styloid fracture of the radius. And on the second picture which you had, it looked as you had another picture in the cast, right? Yeah. I was unsure about the scaphoid, if it's just rotated there or if it's something in the scaphoid too.
Okay, and any other thing you see strange in the X-ray? Okay, so this is the CT scan. Okay, so this is the PA view. It's more or less go slow, but I think even with this speed it's difficult to understand. This is the PA, and that is the lateral view. So the next one is enough for you, the CT scan. You feel comfortable to have a diagnosis with this CT scan? Do you suspect anything?
Can I just make a point about the X-ray? When you see all those chips of bone, you know that you have avulsion of the volar carpal ligaments. And when you see the large radial styloid fracture, you always worry about the potential for a greater arc injury, which we don't see here, but knowing that the radioscaphocapitate ligament is probably injured as well. So I'm surprised that the carpus hasn't dislocated.
You are helping them too much.
Yeah, but I was just wondering.
Come on.
But I was still
Okay.
wondering in this severely injured, how much an MRI actually helps you to really identify.
I think what
structures.
really helps in this is the 3D view, no? For this complex all kind of bones.
Yeah,
our brain is not adapted to do a 3D reconstruction. So I think it's quite useful to do. You have many programs, you can do it by yourself. So in the 3D reconstruction, you find this, you find a fracture of the radial styloid. In the dorsal side, you can see there a small fragment in the triquetrum, a big fragment in the lunate, and then you turn the wrist, and probably the most strange thing is that you have a dislocation of the hamate, okay, and in the volar side, in the volar side you have a fracture of the capitate, along with the dislocation of the hamate, and as Steve said, and this is quite important, in the volar side of the radius is this small chip, okay? So, what is the diagnosis? What do you think with so many things? The next one. So, I will help you. You have injury here, you have a dislocation of the hamate, so the force came here, then a fracture of the capitate, then a fracture of the lunate, and then a fracture of the triquetrum.
So, Giuseppe, what do you think? What?
Smashed wrist.
So what is the name of this? You remember the carpal instability, the last chapter, the last part of all the chapters?
Nina? Arne?
I would pitch for the reverse perilunate.
Perilunate, no. Well, maybe, but not this kind of force. I will help you a little bit. It's an axial dislocation, no? So axial dislocation is really uncommon. This chapter was written by Alex Yuka along with Mark. Axial dislocation are really strange, and this is an axial ulnar dislocation. So the most common one are transhamate peripiciform, perihamate peripiciform. So this one is not in any of this classification, but probably we should call that, maybe we can discuss, a transcapitate perihamate translunate axial dislocation, but also you have this, a fracture of the radial styloid, and Steve has helped you a lot. Because if it is a fracture in the styloid, you said it could be a perilunate associated, no?
Yes, of course.
But also you have, so you also have this, no, transstyloid obviously, but also you have this chip here, and Steve did a clue. If you find this, sir?
Andrea wants to say something.
No, Andrea is not a student. So, it is an axial dislocation, and probably because perilunate injury with transstyloid has been described, but it's really uncommon, but probably it could be a radiocarpal dislocation. And that is why I say that arthroscopy could help, because this is absolutely complex to understand in any classification. But when you scope, you begin to understand things. So this was inside the OR. As Steve said, there was a complete detachment of all the radiocarpal ligaments. So this is a radiocarpal dislocation type 1 because it has a fracture in the radial styloid. In the midcarpal joint, we found that chondral injury, fragments all around the midcarpal joint. But the scapholunate was okay. You can see here. So the only ligament okay was the scapholunate. And we were thinking probably in a perilunate injury. So no, the scapholunate was okay. We removed all the fragment. You can see there the fracture in the dorsal horn of the lunate. We changed the scope, and this is really uncommon to see arthroscopically, an axial dislocation. Again, we remove these small pieces of bone, and you can see that the hamate with the capitate with this motion, we never see this, sorry. And you can see you can go inside with the probe, and also lunotriquetal injury along with the fracture. So really a complex injury. So I go on, okay, so how we treat that. So we put 2K wires in the hamate, and also 2K wires in the triquetrum, just in the bones. then scope again. And like in perilunate, I think the anatomical reduction can heal the bone, but you have to have an anatomical reduction. So you reduce and you cross the K-wires, and we do that the same in the hamate. We reduce the instability and cross until we reach the capitate. So the ulnar side was fixed with these K-wires. Then we went to the fracture of the capitate. So here we put an anterior-posterior screw, cannulated screw. And then we fix the dorsal fracture of the lunate, again with 2 K-wires. And then we went to the radiocarpal, and as I explained this morning, you fix the tip of this is a type 1 radial dislocation, so there is no attachment in that small portion of bone, but you have to fix it. Again, we did that with 2 K-wires. We reduce, and we always do the same, put the K-wires in the fragment and then pass when the reduction is. And finally, we did a suture of the radiocarpal ligament with the same technique I explained for the Volar scapholunate. You can find that in the paper. So we put 2 anchors arthroscopically through the Volar radial portal, one close to the long radial lunate and one to the radioscapocapitate. But I have to finish, so I will go faster. So you can see there one suture, the other suture. 1 second. Okay, so the 2 suture, and we make the knot like that, and we put again K-wire. So this was the control. This is the control after the technique, like K-wires everywhere. So this is after a few weeks and a few months. And this is the last clinical result of this woman, is the left hand. So you can see that it's a complex injury, but once you reduce everything can heal, and he has an excellent result in range of motion and grip strength. So thank you.
Thank you, Fernando. So you're the only one who can show us that climbing the Everest seems so easy. So just the take-home message should be, if you have this, take a ticket to the hospital of Fernando. So the next case will be the case of Lucian. He's coming, Dr. Macrovici is coming from Roma, and he's really outstanding surgeon as well. So we try to challenge the young panel with his case.
So I will present a case, an easier case than Fernando. But when we start to doing arthroscopy, we start to visit a lot of sports people. So we see some unusual cases. So this patient is 27 years old, is a professional climber, and he has for 1 year now a central wrist pain on his left non-dominant pain, and he has pain only during sports activity. So for a lot of us in normal patients, you tell them don't do sports activity, but in these patients it's impossible. So I asked him if he had a trauma, and he told me he doesn't have any trauma. But normally I asked sports people to send me videos of their activity, because not all people play football. And for me, climbing, I didn't really know what is it about. So from all of the videos he sent me, I found this one, and he didn't have any trauma, But for him, it's normal. This is normal. This is no trauma for him, So he told me that he was seen already by several hand surgeons, and all of them diagnosed only inflammation of the tendons, and he wore a splint, and he did physical therapy, and he did everything, okay? But when he climbs, he has pain, and if he doesn't climb, he doesn't earn money, okay? So how do you assess this kind of patients? What kind of examination you do?
Who want to answer? Yeah, go on.
So first of all, this is not a trauma for bouldering, it's just a normal fall.
Yeah,
So,
this is what he told me.
So this kind of fall is usually not painful and you don't fall on your head. The other thing is you have to check out when the pain actually happens, during which movements. He has actually to describe you when it happens. Is it during the grip strength, during force-aided ulnar pronation? Does he have some clunking in the wrist? I mean, when you think of climbing, you think of repetitive sports, so maybe non-dissociative instability. So you have first to do a checkup of the wrist clinically. He has to describe it to you.
Great. So clinically, I will only anticipate this. He doesn't have any clinking. He doesn't have pain during physical activity. Doesn't have anything. He tells me that he feels pain only when he climbs. Okay, only when he climbs. Physical examination was totally negative, and it was negative in all the hand surgeons that evaluated it.
So no stress test positive draws?
Everything was negative clinically.
Maybe faculty can help us.
And then I would proceed to imaging.
Okay, what kind?
First you need like basic X-rays.
Okay, this one.
In comparison to the other one.
Where's his pain?
Where's his pain?
Where's his pain?
He tells me that it's in the center of the wrist.
On the back of the wrist.
In the center.
Okay.
He tells me in the center. He always feels pain in the center of the wrist.
Is he hyperlax?
No, he's not hyperlax.
But you already did the clinical examination?
Yeah, I did the clinical examination. It's totally negative.
No ulnar sided pain?
No ulnar sided pain, no central side pain, nothing.
Do you have comparative dynamic X-ray?
Here it is. I know you, Christoph. I'm ready.
You checked properly the lunotriquetral space? I'm sorry to ask the question, because climbing...
I did hear the risk score, so what you taught me, I did.
I have just one question for Sanji. You told me yesterday that you saw a lot of sports, professional sports in your daily practice. What would be your first thought when someone is consulting you for this kind of...
So sometimes you see these patients who only have pain doing the sport, to actually get them to do the sport. And so there's times where it's been on tennis court and gone with them and seen where it is to really hone in on where the pain is. Like Christoph mentioned, the index finger is the best clue.
Yeah.
And so that's what I would try and elicit with this, because complaining of just pain, right, and you can't deduce it on clinical exam. The only other thing that I thought was wrist extension.
This is why I asked them videos of the activity, because it's actually a good tip. I think it's important to understand when they have pain and what is their real activity, okay, and what is their effort.
Very often at this stage, I'm like you, I see that everything, it's look like a small dorsal ganglion, and we need an MRI.
Okay, here's the MRI.
Sorry, Lucian, I asked my patient to climb off, to be on hyperextension in the table in the office.
Negative.
Negative for you?
No, it was negative.
And
here's the MRI, like Christoph said. It's negative, okay, nothing. He has a little bit of tendinitis. We will see it in the axial view, but I have everything.
we prepared before.
Yeah. So no ganglion, and only a little bit of tendinitis, but maybe it's normal. So
to complete everything,
now,
kinematography.
What?
Dynamic fluoroscopy.
So I did a dynamic test, but I did an ultrasound. I have it in the office, and I think it's very, 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 very useful. We have now a lot of ultrasound courses. The IRCAD has a very important course. Fernando has a very important course of ultrasound. Also, we in Italy have it. And so the only thing I saw is this. So while doing a dynamic ultrasound examination of the volar aspect, I saw only in the left wrist a small opening of the volar part. It's the only thing I saw. And I really thought to myself, I'm fortunate to have the ultrasound, because I probably wouldn't have a solution for the patient. So I spoke with him about maybe he has a volar lesion of the scapholunate. But how would you confirm it?
Sorry, just one question, Lucian. If we don't have the chance to have the device at the office and no radiologist is skillful, do you go directly to scope it? Do you think you
Before I used ultrasound, I scoped it directly. The problem of professional players that they don't want to do surgery. They don't want to lose time in staying home, not doing activity. They want a concrete solution. No, maybe you have this lesion, we do arthroscopy and we will see. They look at you as an expert and they want...
Send him to Fernando.
Yeah?
I would. Just a comment. Sometimes a lidocaine injection is helpful.
Yeah.
Sorry, Steve, you were going to say
I was going to say the same thing, Sanj. Otherwise, also, after 3 months of undiagnosed wrist pain, it's very appropriate to do arthroscopy. They may have an osteochondral lesion. They may have something in the joint. It's very reasonable to do arthroscopy.
But sorry, excuse me for the arthroscopic diagnosis in a high-level sportsman. We enter the wrist, we do a diagnostic arthroscopy, but how we correlate the lesion we will see, the supposed lesion we will see intraoperatively to the pain, because we don't know where is the pain. And maybe there have been several pains before. So I prefer lidocaine, I'm sorry, Steve, I prefer lidocaine injection tests than going directly to the scope in these cases. So that's my opinion.
I mean, if the patient is very reluctant to have surgery, sometimes a 3-phase bone scan also may be very helpful.
Absolutely. So,
just last question. If you have the test of lidocaine, where do you inject? Because you have to be precise. So, I mean, if you inject lidocaine in all the wrist will be painless and fun. And the guy will ask you to have some pills or some shots for each session he has to climb. So, how can you be really precise when you need to make this injection?
No, it's a good question, right? This is basically ruling out intercarpal pathology versus not. That's all you're testing with a lidocaine injection.
I think you also have to understand that lidocaine is cartilage toxic, so that multiple lidocaine injections may also cause problems. I found it best when I'm trying to differentiate between arthritis at the one joint and arthritis at the other joint, that's when I find lidocaine the best.
So actually, in this case, ultrasound, which is very simple exam, helped me to notice the patient as a problem, and he asked me for a solution because he was convinced that this was its problem, because he saw it during the examination and he saw that the other side was negative. Okay, so I did an arthroscopy. Okay, and I found a small opening of the volar portion of the scapholunate and the central portion, and the dorsal portion was completely closed. Okay, so what are the options? What should I do?
The young panel, because we gave you several options. So since you're good ones from the expert and basic course, yeah, go on.
If I would be Fernando, he would do it probably arthroscopically. If I were me, I would do it mini open.
And what kind of open surgery would you do?
I would build a Volar approach to the Volar aspect of the SL ligament and try to not suture it, but to tension it.
So you would do this one?
Yes.
Okay. I think.
Of course.
I think the.
So Steve, you won.
Yeah, I think that the technique of Steve is very intelligent as an open approach. It really opened our mind of the role of the radiocarpal, volar radiocarpal ligaments, and open a way of thinking to use them as a reinforcement in order to treat these kind of lesions. Okay, so, and if you do an arthroscopic way of treating it, how would you treat it? Giuseppe?
Probably just the same way we've seen this morning. I mean, as Fernando tried to show us. I mean, if you got the skill, I would try that. But I would probably just make sure that I've got the skill to do this.
Okay, so you can start with an assisted approach. Okay, maybe from which we saw from Kakar, or you can do the arthroscopic approach of Fernando. Okay, or you can do the all-inside percutaneous approach of Paco del Pinal. So there are a lot of options that you can deal with the volar aspect of the scapholunate, but nobody speaks about the volar aspect of the scapholunate. When you go to congresses, everybody speaks about the more important brother, the dorsal part. So we have a lot of options for all kinds of skills. And I did an option that was taught to me by Andrea when I went to visit him. And so actually, again, we diagnostic the scapholunate volar portion lesion, okay? And then I prepared an 18 gauge needle, a little bit curved in the distal part, and I put a number 2 fiber wire on it. And then I go with the scope in 3/4. You can visualize really good the ligaments, the radioscaphocapita, the long radiolunate ligaments. Percutaneously, I enter in that point, okay, with the needle. I retrieve one part of the fiber wire towards the 1-2 portal. Okay. Then I go back under the ligaments. I go all around the ligaments and go out at the T2 ligament. Okay. And then I retrieve the other part of the fiber wire to the 1-2 portal. Okay, then I have the 2 parts outside the 1-2 portal, and then I do a retentioning, a suturing, arthroscopic sliding suture. So I actually unite the 2 ligaments, okay, which is the same principle that Stephen Moran gave us, and you can see it's closed, okay? So it's a very simple, very fast way, okay, with small incisions, all dorsal. And this is the patient. And he was going good. He was very happy.
And so, just one question. What about the cartilage with the thread inside the joint? The cartilage, you know if there is some damage of the cartilage because you leave the thread inside the joint?
No, you saw the thread or the suture?
Or the knot, yeah.
The knot, it's actually under the skin. Okay. It's not inside the... So I thank Andrea for teaching me the technique, but I think that the most important thing is to see all the colleagues, to know the story, the history from Moran, the mini approaches, the mini open approaches, the arthroscopic approaches. All the people that you see in these courses give you something for your career and for your ability as a surgeon. So I thank you all.
So I would like to add something because I think it's very important, because it is a demonstration, once more time, that the extrinsic ligaments are really more important than the intrinsic ligament. It is very important, dorsally and volarly. And thank you for this presentation, because it's just a wonderful example.
So now we traveled to Spain, to Italy. We have a ticket to Rochester for the last but not least case from Sanji Kakar.
It's a great session. Congratulations to the 3 of you for putting this on. So there's no red herrings in this one. Okay, there's no booby traps here. So this is a gentleman who comes in, active gentleman who comes in, and he'd fallen down the stairs a couple of years ago. And I think the diagnosis is pretty obvious here. So just looking at this, what do you think? What's going through your mind in terms of imaging tests? what you would like to do.
So go on. Who hasn't answered any question?
Yes, so first I would take a more detailed history and physical exam, but just looking at the x-ray you would suspect a scapholunate lesion, and since he fell 2 years ago I would also worry about the reducibility of the lesion at this point.
Yeah, no, great. So clinically was tender over the SL with a positive Watson shift test, and the grip strength was about half the uninjured side. And so this is his lateral X-ray. What do you see? What goes through your mind here?
Yes, so you see the...
It's funny how you have to turn your head like that. When I have it straight up, I have to turn it this way.
But you know, Sanji, in France we're the opposite. You will see like this. Because, yeah.
So the scaphoid is severely flexed. And yeah, so you have a DC deformity.
So do you have enough information there? Would you get any other tests?
Well, I would do an MRI as well.
Okay. Sometimes we get motion series to see reducibility. I've sort of stopped doing that. It just takes extra time in clinic, to be honest. It hasn't really changed what I do because of arthroscopy. But this is the MRI. And so you can see, as you correctly pointed out, I mean, it's essentially dorsal dislocation, not subluxation, big gap. And just as Steve showed a case earlier where it stretched out, the scapholunate, to me, that was like toffee. It completely sort of delaminated. So 2 years out, what are your thoughts here? Now what would you do on this patient? Young patient, active patient. You mentioned reducibility, so that's one thing. If it was reducible in your mind, what would you do in 2024? And there's no right answer, as you've clearly seen. We're all different.
I think it's important to also have a good look at the cartilage.
Okay. So you would do an arthroscopy?
Yes, I think I would discuss the possible options with the patient and then do an arthroscopy to make a final decision on what to do.
So scope the patient, get the information, come back another day. Okay, everyone in agreement with that? So for me, this patient, I did scope him at the time, and we did everything at the same stage. This to me was the upper limit of what I can think I could do arthroscopically a few years ago. I think now we're learning more and more of these techniques, which are more powerful. But for me, this was an SL360, and the goal here was to address this without K-wires. You know, I've done some of the other ones, and you leave the K-wires in for 10 weeks, and they can't move. So I wanted to get these patients moving earlier. I think the key thing about any of these procedures that we've discussed, especially with transosseous drill holes, as Dr. Moran mentioned, is you have to know the complications. I think that's absolutely critical. We're learning more and more about problems with the anchors, problems with the tape, and with the drill holes. So for me, I did not feel that I could get this arthroscopically. So it's okay to open, right? Even though it's an arthroscopic course. And so you can see this is a through and through injury. And then the key thing is in terms of the graft. Now I use plantaris allograft. To be honest, it's easier to pass through the drill holes than palmaris, because the graft can't be more than 2 to 2.5 millimeters. And by the time you harvest this graft and you trim it down, it actually takes time. So I get the graft, I whip stitch it, I put it on the back table on an ACL tensioning guide to take out the creep of the tissue. This is a very powerful slide by P.C. Ho, who described doing this arthroscopically with this box reconstruction. And the key thing is if there's DZ, your drill holes through the scaphoid are dorsal distal to volar proximal. If there's no DZ, you make parallel drill holes. And Fernando showed in his videos how critical those drill holes are. I mean, this is the whole case here, right? This is where you really have to take your time to make sure, especially the lunate hole is in the middle of the lunate. And people cheat, and they cheat too distal, and you're a risk of going in the mid-carpal joint. And the lunate is actually much wider than you think. So if you put a freer in the radiocarpal joint, you can really see the proximal aspect of the lunate. So the drill holes, it's a 3 millimeter hole in the lunate and a 2.5 in the scaphoid. The reason is because the graft is going to go around twice through the lunate. And so here the graft is going dorsal to volar through the lunate, and then volar to dorsal through the scaphoid, thereby reconstructing extra capsularly the volar sort of SL and extrinsic ligaments. And so now, remember, there's a 3 millimeter hole in the lunate, and so the graft goes through and through. And so the key thing is this reduction clamp gets your reduction. You're not pulling on the graft to get your reduction. But the key takeaway for me is this part. So I've always been concerned that when you put the tape through bone holes, the tape can cut out through the bone. But in this way, what you're doing is that you're putting these biotinadesa screws, and if you've not used these, take the screw off the driver first, because you may have seen in the lab, they're like cold welded on, and you put it in and sometimes you'll hear a crack. It's not the bone, you cracked it and the driver is broken off in the screw. And once that happens, you'll never do that again. So take it off, wipe the driver in some fat, and then put the screw in. But the advantage is that through that drill hole, the cannulation in the screw, the actual suture goes through. So the suture is actually sitting inside the screw as opposed to cutting out through a transosseous drill hole. So that's volar and that's dorsal. Then you take, there's a limb coming out dorsally, you anchor that to the distal pole of the scaphoid to prevent scaphoid flexion. And as Dr. Moran mentioned, long radiolunate ligament, at first when we described this was for Telesnik 2, but I think it's very hard to determine the quality of the long radiolunate ligament. And so routinely now we reconstruct the long radiolunate ligament with this graft and tape on the palmar side. When you do this for the first time, so in your approach, it's basically distal to the pronator quadratus, check an x-ray, because you think you're in the footprint where the long radiolunate ligament is, and you're either too ulnar or too radial. And so it's humbling to see where your K-wire is at first. So we check, so you may say, okay, what's all this thing about the tape? Why is tape important? So we did a biomechanical study, and basically what we found is that just doing this tenodesis reconstruction with graft only, and then combined it with tape, the braking strength, natural dorsal braking strength, about 320 newtons. You can see that it was double adding the tape compared to not. And so again, the genesis is not to put K-wires. If you have to put K-wires, that's fine, but we're trying to move away from that. And so the other thing that we wanted to do was look at our outcomes. And so these were 3 academic centers in Pittsburgh and in Ortho Carolinas, because invariably when it's somebody who's designed something, their results are good and everybody else isn't. So we wanted to see if this was reproducible amongst all of us. And so we collected, it's a small series, we need longer follow-ups, but clinically and radiographically, these patients were doing okay. So this is that patient at just under a year of follow-up. It's not perfect, it's better than before. The key thing, as we talked about, I think these last 2-3 days, is correction of that dorsal translation. So this was the CT scan that I didn't share with you pre-op. You can see that scaphoid's at 90 degrees, and then post-op, you can see we've corrected the dorsal subluxation. So just wanted to share, just in terms of thought processes, different ways of skinning a cat.
Thank you, Sanji. So we have time for some of questions on the chat.
Thank you. Thank you, everyone. We have a question in the floor.
Sarge, thanks for a nice presentation. I've also been wondering about the suture tape, how it goes through the bone. And you have tried to solve this by going through the interference screw. But the screw doesn't go all the way through the bone, it's just half the way. So, and when it exits or goes into the bone, then you don't have any support for you don't have any protection between the suture tape and the bone. Is that correct?
Yeah.
So you may have a problem there.
Yeah, so you're thinking about the sort of width of the bone. So you're right. So if you actually measure sort of the width of the proximal pole of a scaphoid, it's over 1 centimeter, and the screw is 3 by 8. So it's not all the way through. But I think it's sufficiently through, but you're right, I haven't seen anything volarly, but maybe that is a point of concern.
Yeah, that's why I'm waiting for the long-term result, because it's, especially through the lunate.
Yeah.
There could be a problem.
Yeah, it's a good point, good point.
Yeah, there is a question, yeah, please.
I have just one question out of curiosity concerning the biotenodesis screws. We know from knee surgery that there were problems with the resolvable interference screws of the knee and the tibial. in concerns to inflammatory reaction or tunnel enlargement, autoimmune systemic reaction. So in knee surgery, we try to avoid them if possible. Are there similar cases happening in hands too in the carpal bone or not?
Yeah, it's an excellent question. And I think, honestly, we don't know. We're beginning to find out, right? The question is it the screw? Is it the tape and the wear? Is it the iatrogenic trauma of the drill hole? So in that paper, one thing that we included was a patient that I did it in a perilunate patient. And I actually caused some ischemia to the lunate. Now, I followed him for 4 or 5 years and it didn't change, but that was a technical failure on my behalf. So this procedure, if I get an MRI and there's any edema in the carpus, to me that's a carpus at threat. I do not do this because I worry about that. But excellent question.
Any other question in the panel? So we have some question on the chat, yeah?
Yes, I have a question. I didn't really understand this question from Eleni. How much tape and plantar is allograft typically required for the 360 SL tenodesis?
Is it required? No, sorry. No, it's not required. I mean, I usually use a palmaris.
Yeah.
It's just quicker, honestly. And the other thing is passing the plantaris allograft is easier through the drill holes, and it's a thinner tendon than a palmaris.
Okay, thank you. I have a more general question from the chat just earlier from Uldis from Latvia. The question is whether reconstruction with tendons can be replaced by dorsal and volar capsulodesis. If yes, in what cases? It's a more general question. For you maybe, or for Steve, or because Fernando left.
I think if there's a lot of ulnar translocation, or if there's a substantial amount of DC, I think those are difficult to correct with capsulodesis. You need to use some type of, I think you need to use some type of tendon.
I have a question for this, actually, for, do you think in some cases we can perform intraoperatively extensive debridement to reduce some non-reducible cases? Because I do usually this because we were talking about the skills to do reconstruction, and not everyone is capable to do corella reconstruction. So in some cases we can go back to a reducible and do some reinforcement, large capsulodesis. Do you have any experience with this?
I think Paco reported on reduction of arthrofibrosis. Didn't he right around there?
Yeah, so I think it's an excellent question. And that's why I've moved away from getting dynamic series x-rays, because many times you go in there and it's mainly in the mid-carpal joint. And if you take your shaver, and it's as if you're shaving sort of the membranous portion, but you're between the scaphoid and lunate, and you're taking your shaver moving up and down. And many times you can say something that is, I wouldn't say grossly irreducible, but irreducible-ish, to make it more reducible with using a probe.
Actually, I used to do this, but it was not really efficient. So now I take a small device, I go dorsally between the bone and the DIC, not to detach the DIC, be careful, but just to release a little all the fibrosis and the synovitis you can have in this very special area. And it's really useful to do this.
In the radiocarpal joint?
In the mid-carpal joint.
Mid-carpal,
yes,
okay.
Just in this.
What device are you taking?
Just a small device, not the one we had in the lab. I don't really know in English to say the spatula. Sorry, okay. The small spatula.
Just a more general things about this. Do you think we are just doing like a knee surgeon because they make big release? And as hand surgeon, we don't have this experience that we need to release something in order to create motion and then stabilize. When I was young resident, they told me when it's fixed, you can't have more motion. I mean, when there is stiffness, the stiffness stays. And then we're just talking that maybe we can create motion and then make more stabilization. And I think it's really interesting to tell to the people that when you use a scope and you have mini-invasive techniques, you can free a lot of space, a lot of room, and create something easier to treat than what you expected to see before enter the OP room. And it's really exciting to create a new way of treating those scapholunate instability. What is your feeling about this?
Yeah, I don't think you're creating motion, you're basically getting the carpus reduced, because many times it's malreduced, right? And so you're just decreasing scar to get the reducibility, but then you're doing something on top of that. You're not just reducing scar and you're done for the day. Then you're doing your reparative techniques or reconstruction.
Yeah, Shab, it's really interesting what you're saying. I think it's completely true. Not only you're creating some room and some space to facilitate your repair or your reconstruction or reinforcement or whatever, but not only by that you debride and you create some scarring, some good scarring, healing of the tissue because of debridement. I think makes your repair even stronger, actually.
Could I just ask one question out of curiosity? Of the ones who do this arthroscopic assisted, who does the corella and who does the PC hole? Could I ask you who does the corella? Here?
Left.
And the rest of us? Okay, so who do the box? Okay. Thanks.
But don't forget that is a very technically demanding procedure, and this kind of procedure are to be reserved for very special cases, not for
you know,
all
hiking is a big sport, so I try just to go on hills, not on the Everest. And for Fernando, it's a big Everest. So if I'm able to make it, maybe I will be interested. But it's really tricky and demanding. So if you have any complication, you have to address the patient after. So keep in mind, for me, it's a culture. It's really important to know it, but you have huge experience before trying to make the good indication and then to go further with the upper room and be self-confident with those kind of techniques.
But I have to admit that we have tried the corella and we did it, but you have to be very precise with the tunnels. And I think the box technique, it's probably easier and the results are not different. So then the question is, what do you want to do?
One thing important is when you perform the box technique, it was not like that at the beginning of the PCOS technique, because now he passed outside the extrinsic ligament. It's very important.
So the key point would be that the scapholunate ligament, when we were young, is that it's the key point. We have to stitch it. At the end, if I understood everything, it's the least part of everything we talked. We don't need to stitch the scapholunate. We need to address everything around. Right, so the diastasis mean nothing for me, and ligament mean nothing. It's not a ligament at the end, it's a complex. And all around is more important than what's inside, right?
No, I think you agree. I think we don't know, truthfully, right? But I think what we do know is how important these structures are. And so I don't know if I would say in 2024 I'm just doing extrinsic work only and ignoring the ligament, but I think certainly the extrinsics, we call them secondary stabilizers, you know, people now calling them critical stabilizers, I think is a good notion.
But we are talking about extrinsic, primary, secondary. What do you think? You presented cases with volar instability, and you know we are from the dorsal school. And I have a question. When we do our capsulodesis, enlarged capsulodesis or application or anything from the dorsal side, we close the volar space under arthroscopy. And first, how do we explain this? Secondly, which anatomical structures is involved in your, I'm not going to say supposed volar instability, because we don't know exactly which structure. We know that Ezekiel Zeidenberg is starting a study that trying to do sequential sectioning of the volar at the ST level, but he's not really sure. He showed in Madrid his first dissection. Could you answer this question, please, to the dorsal arthroscopist I am?
I don't know if we are closing the volar part. I mean, you're looking through the scope, you're pulling with the patient on traction. I think that's why we really need to advance our 4D CT and our dynamic MRIs so we can see what is exactly happening to the patient afterwards. I think you're preventing dorsal subluxation of the scaphoid, so you've taken away pain. You've definitely, I think there's benefit to closing down the DRC and the DIC, and I think that controls scaphoid flexion as well. But I don't think we really know dynamically what's happening to the bones through all arcs of motion until we're able to look at the motion live.
So intraoperatively, if we release the traction, if we do all the tests arthroscopically, it is not a good specificity. That is what you are explaining.
I'm saying you're just seeing it in one position. It definitely makes a difference.
Yes.
You know when you pull it, you have a good piece of the ligament, but I don't think you know what happens when it's loaded and the patient is in flexion or when the patient is radial deviation.
We can do arthroscopic dynamic tests. I'm not, yes, that is possible, releasing the traction, but I totally agree with you. Thank you.
Yeah, Jan, please.
I have one more question, because I totally agree with what Christophe said. You have to go extracapsular. And then it's one question for you, Sanj, because you have good results with your 360 degrees. But do you attach the dorsal intercarpal ligament to your reconstruction or to your tendon graft?
Excellent question, Jan. And yeah, in the interest of time, we didn't show that, but the dorsal capsular closure is absolutely critical, getting the DIC and DRC ligaments down. I respectfully disagree, but I won't be disagreeable with Dr. Moran, my senior partner. But I've heard about obviously the window approach. My concern with the window approach is a couple of things. Number one, when you're putting these drill holes, it's very technically, they can be demanding. And so I want to see exactly where I'm putting that, number one. Number two, I think in some of these scapholunate instabilities, the attachment of those ligaments has stretched out. So while it's still adherent on the bone, it's not functionally competent. And so we have to sort of repair those back down. And so that's why I think the capsular DCs work, because you're tightening those structures back down. So still, I'm still happy doing the ligament splitting approach, but I understand there's two camps that are forming now.
So to sum up, maybe the next decade we will have to fight against the Volar school and the dorsal school, right? And forget the scapholunate ligament. That's it. I try to take home a message for me, because I'm still mixing my mind, and I don't know. Mr. Matulin told me you have to go dorsally. Now we're talking about palmar stuff. So what am I supposed to do on Monday with my patients?
It's very much like a door. It's got two hinges. If you just leave the top hinge intact, the door will still open and close, but it's not biomechanically sound. You have to fix both hinges for the door to work sound.
Makes sense.
Yeah.
So yeah.
So do both.
That is Mayo spirit. Yes.
Doing both maybe it's not what we should do, because it can be antagonist. Maybe.
She needs only one hinge. That's all.
Wants to leave it unhinged.
Yeah.
I think that the important thing is the blood supply it's just like the TFCC. Fixing the central part, there's no point. It's just debriding and relying on the extracapsular structures to heal back down. I think it's very hard to get inherent healing of the SL, volar or dorsal.
Thank you. Yes.
Any other question for this exciting topic?
So this is for the open approach. So if you have a severe dizzy with ulnar translation and you decide to do an open reconstruction, do you always get it reduced? Okay, and then you go to salvage? Or?
No, I think if there's ulnar translation, for me, I have to reconstruct the radioscaphocapitate ligament, so it's an indication for an anafab type repair, because as the ligament comes out volarly out of the lunate, you have to attach it back to the radial styloid. The concern is that repair limits motion, and also, as Dr. Corella has shown, that it causes a tremendous amount of shearing on the volar opening to the ligament and the tape. And I think that's why we're seeing osteolysis at the entrance and the exit of the tendon repair, and nothing around the peak screws. So I'm concerned long-term that will cause problems.
Just to conclude, a very short question is a key from the chat. Is a key wire necessary for the 360 procedure?
It's not necessary, no. But what I would say is it's totally down on the quality of the reduction, right? If you're doing it and it's not great, certainly put a K-wire in. I mean, we've grown up doing that, right? And so I have no qualms. More of a scaphocapitate as opposed to a scapholunate, because you can shear your graft if you're not careful.
Thank you.
So we will conclude this session. I'm really honored and glad to have shared some kind of mentors, really interesting stuff. And I hope that all the panel has been really excited talking about this topic. And next May, we will have another topic, and I hope a lot of people will attend on the internet or here in Strasbourg. Thank you very much.
Thank you.
Last word, I would like to thank a lot, really, all the experts coming from everywhere, because this session for me was exactly what we would like to do for whole courses. It was absolutely perfect. Thank you very much. Thank you for the participants. It was a great pleasure to have you, and we are waiting for you for the next courses, and you have to become experts, because look at us, we are old now. We need you. So thank you very much.
On site. Learn from the very best experts in your surgical specialty and make the most of our exceptional facilities equipped with cutting-edge technology. Train and learn from the best, but also relax. Discover the magnificent 4-star Hotel Liara, as well as the Brasserie Liara, run by a Michelin-starred chef. It's the perfect place to talk to the experts and have a relaxing time. And don't worry, it's very easy to get to Strasbourg. You can get there from Paris, Basel, or Frankfurt, for example. Join us today. This is the best way to learn.